All right, let's get started. Thank you all for joining us. I'm sure we'll have some people straggling in the next few minutes, but we've got a lot to talk about today, so I want to get going right on time. Welcome to the second session of the SDOH Academy's Learning Collaborative on addressing social determinants of health in rural areas. My name's Kristen Steimanoff, and I am with Health Outreach Partners. And during this 4-session learning collaborative, we're being joined by our colleagues at Migrant Clinicians Network, the National LGBT Health Education Center, and Capital Link. There will be 3 additional learning collaboratives hosted by the SDOH Academy between January and June and presented by other National Cooperative Agreement organizations. Next slide. We are there we go. We're working together. I am doing introductions today. We have Liam Spurgeon in our office working on technical support and Christina Wharton also off-site clicking through slides. So please bear with us if there's some technical glitches. But last week was the first session of this Rural Health Learning Collaborative. My colleague Christina Wharton and I kicked things off with a session that focused on key issues and risk factors facing rural communities. And we talked about identifying and understanding unmet need and connecting with people through outreach, and started talking about some strategies for connecting people to care, taking into account challenges and barriers that might be especially pronounced in a rural setting. But today is very focused on understanding trauma to meet the SDOH needs of rural populations. And our colleagues at National LGBT Health Education Center and Migrant Clinicians Network will host today. We're going to take a break next week for Thanksgiving and come back together for our 3rd session on November 27th. And that session is going to be about challenges and opportunities for collecting SDOH data in rural health centers. And then our final session will be the first week of December. On December 4th, Capital Link is going to be joined by a health center representative to talk about financing infrastructure development in rural communities. So we have some really exciting things lined up for you over the next few weeks. Next slide. So as we did last week, for those of you who were here, we're using GoToWebinar. And if you do have any technical issues, you can call their technical support line directly. The number, if you can't see it on your screen, is 1-800-263-6317. But we also have Liam in our office helping with technical support, so you can use the question box to chat him if you have questions. Right now, you're all in listen-only mode, but we can facilitate virtual conversations using some of the communication tools. So if you see on the right-hand side of your screen, that control panel, there's a little hand icon. You can raise your hand if you have a question and we can communicate with you, or you can type into this question box and we can communicate with you that way. So we are going to start out by asking participants to introduce yourselves, and then we'll turn it right over to our presenters today to introduce themselves and start the show. But to get us going, please, in the question box, type your organization name and your first name, and we'll just introduce people as we go. Okay, we have Angela Castro from Variety Care. We have Whitney from Kentucky Primary Care Association. We have Nat from Montana Primary Care Association. We have Tricia at the Kansas Association for the Medically Underserved. Donna from Central County's Health Centers in Springfield, Illinois. Terry from Kansas Association for the Medically Underserved. Margaret at Cabarrus Rowan Community Health Centers. Mary at Variety Care. Kelly, Theresa, Lindsay, and Carrie from Southwest Montana Community Health Center. Megan from Community Clinic. Sorry, I can't see it all the way. I'll go back to that. Taylor from Colorado Community Health Network. And Rob and Sabrina from Mountain Laurel Medical Center. Debbie, Dana, and Clarissa from Mora Valley, CHS. And Megan is with Community Clinic of Maui. Sorry, I couldn't see the whole thing. Debbie, Dana, and Clarissa we got from Mora Valley, CHS. Okay, I think that is all for the moment. So let's jump right in, and I will let Alex and Theresa introduce yourselves and start your content.
Thanks so much, Kristen. Hi, everybody. This is Alex Kuroglian. I'm a psychiatrist at Fenway Health in Boston, and I direct the National LGBT Health Education Center, which is a national cooperative agreement focused on training and technical assistance to improve care for LGBTQ patients at health centers. Theresa, would you like to introduce yourself?
Sure. My name's Theresa Lyons Clampett. I'm the Senior Grants Manager for Migrant Clinicians Network. We are a national organization and do actually some international work as well, located in our corporate office in Austin, Texas.
Thanks, Theresa. Next slide, please. We have no disclosures. Next slide. It's great to be here with you all today, and we're going to focus, again, as is the theme of this learning collaborative, on social determinants of health. Specifically, we're going to focus on the role of trauma-informed care approaches throughout health centers to address the adverse impact and mitigate some of the damage that certain social determinants of health can lead to for our patients, for our staff, and for our trainees. Just to review what social determinants of health are, I know that we had a great presentation last week by Kristen and Christina, where we reviewed a lot of the basics already. Social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. This is the definition from Healthy People 2020, which was much of the impetus for focusing on social determinants of health in the primary care work that we do and in the public health work that we do more broadly. Social determinants of health can be advantageous or lead to adverse consequences as well. And certainly when we're focusing on traumatic experiences related to various social determinants of health, these are typically circumstances in which things are not optimized in order to engage in these different aspects of life that we've highlighted here through the Healthy People 2020 definition. Next slide, please. What is trauma? There are two ways in which this term is used. There's the very traditional sense in which we refer to trauma, and as a psychiatrist, this is often how we refer to it. It's certainly how we're trained and how we practice and how we diagnose something like post-traumatic stress disorder. The idea is that there would be some kind of initial index traumatic event, like being in combat, a terrible car accident, a sexual assault or physical assault, seeing someone you love being attacked or being harmed. And the thinking has been traditionally that this kind of index event is needed to have symptoms of post-traumatic stress disorder. That can include intrusive thoughts, avoidance or numbing of things that remind you of traumatic experiences that you had, and hyperarousal, startling, being hypervigilant, for example. We've evolved in recent years in how we conceptualize trauma and the impact it has on people. We appreciate now that life circumstances, everyday challenges, microaggressions over time, for example, can lead to symptoms of post-traumatic stress of the kind we used to think only occurred with an index traumatic event. We've done studies in this regard as well. For example, with stigmatized groups showing that everyday discrimination, microaggressions can lead to clinical post-traumatic stress syndrome. So what is trauma more broadly? It results from single or recurring events or experiences that cause serious threat, loss, or harm to the individual. Trauma overwhelms a person's adaptive coping skills and can have a lasting adverse effect on the individual's functioning and mental, physical, social, or emotional well-being. So you see it's defined very broadly, and this is somewhat adapted from the definition SAMHSA uses for trauma. Next slide. SAMHSA has also defined trauma-informed care, organizational approaches in healthcare settings that can mitigate the adverse impact of trauma and prevent re-traumatization. According to SAMHSA, a trauma-informed service organization is one that realizes the widespread impact of trauma, understands potential paths for recovery from trauma, recognizes signs and symptoms of trauma in clients, staff, and others involved with the healthcare system, responds by fully integrating knowledge about trauma into all policies, procedures, and practices, and seeks to actively resist re-traumatization of anyone who interacts with the system. So you can see it's very all-encompassing as an approach. The idea is to infuse these evidence-based principles of trauma-informed care and best practices into all facets of the organization with which people may engage and how people engage with one another as well. Next slide, please. Trauma-informed care has emerged in recent years as more of a national priority than perhaps it had been in the past. Several evidence-informed treatments designed to improve post-traumatic stress symptoms specifically have emerged and have a very robust research base backing their effectiveness. Implementation of these treatments and strategies, however, to target the effects of trauma on health has been quite inconsistent. It's been hit or miss, and certainly that's been the case at health centers as well. We see particular disparities, for example, between urban and rural health centers with regard to the likelihood of these rural health centers implementing evidence-based trauma-informed approaches. Part of the reason this has emerged nationally as a priority, in addition to the development of highly effective evidence-based treatments, is focus on veterans returning from combat from Iraq and Afghanistan with post-traumatic stress. And in fairness, the VA is really very far along in terms of implementing evidence-based trauma treatments. There's, for example, a requirement that every VA have a cognitive processing therapist at evidence-based treatment for PTSD on site at the VA, and over 98% do. So the onus is on us within the health center world to try and make evidence-based trauma interventions as ubiquitous. Next slide. What are the components of trauma-informed care? It should incorporate the following: a trauma-sensitive practice environment. This means trainings to ensure a sense of safety in all interactions with patients that staff members have, including both clinical and administrative staff. Identifying trauma, experiences of trauma in our clients, and mediators of trauma. So consequences of post-traumatic stress, like poor adherence to treatments and various high-risk behaviors, whether it's substance use disorders or high-risk sexual behavior, for example. Education for patients about the connection between trauma and the negative behavioral and physical health outcomes it can cause. Folks often don't realize that traumatic experiences they've had in their lives, broadly defined, can have a direct impact on things like medication adherence or physical health. So helping our clients gain more insight into that reality can go a very long way. And linking folks to suitable resources and referrals for more specialized treatment is key. This is something we'll focus on a little later in the presentation as well. And I shared with you all an article about telemedicine being used to deliver evidence-based trauma treatment to a young patient in a rural setting. So we'll talk more about telemedicine in a bit. Next slide, please. SAMHSA has established a fantastic National Center for Trauma-Informed Care. This center has a wonderful website. You just Google National Center for Trauma-Informed Care, you'll find all these terrific resources that promote awareness and implementation of best practices in trauma-informed care, disseminate various cutting-edge resources, referrals for trauma-focused treatments, and defining trauma-informed care at the center, not in a very rigid one-size-fits-all way that's hard to adapt, but really as a guiding set of principles that focus on being mindful of and responding to folks who have experienced or may be at risk for trauma, making sure that this is something flexible but substantive that can be applied to any healthcare organization. Next slide, please. I'm going to focus a bit, and I know Theresa is going to do this as well, on stigmatized identities as a social determinant of health and the trauma that's associated with this. This is an adaptation of what's called the minority stress model that was initially developed by Mayer. And the idea is that folks who have a stigmatized minority status, minority identity, developmentally from early childhood to older adulthood, will experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a much higher prevalence than non-minority counterparts. And this, over time, can take a toll for many people, lead to disruptions in general psychological processes like emotional regulation, coping skills, interpersonal functioning, cognitive structures that aren't adaptive, like believing it's never going to get better, nobody can be trusted, no one will ever care about me, for example. And all this external stigma-related stress, these social determinants, the violence and abuse that people with stigmatized identities encounter all too frequently, can also lead to internal stigma-related stress. For example, internalization of negative societal attitudes about oneself, becoming very sensitive to rejection. This is something, for example, that racial and ethnic minority people, sexual and gender minority people, lower socioeconomic status people, and even folks in rural settings, certainly, to the extent that they either do or don't intersect with some of those other identities, can very much experience. All of this stigma-related stress, we think, over time, is associated with what we observe in the literature for many stigmatized minority populations, which is a much higher prevalence of behavioral health problems, like a much higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders as a way to cope with all this stress, decreased self-care, decreased engagement in primary care, and down the road, a higher prevalence of various physical health problems as well. Now, it's important to note that all of these stigma-related social determinants, these environmental circumstances, don't necessarily result in maladaptive coping or adverse health outcomes. Having a stigmatized or minority identity is also an opportunity to build resilience and to have what we might call, some refer to as post-traumatic growth. This can be a source of positive health outcomes if somebody is able to develop resilience in the face of this kind of adversity. Next slide, please. So we combine this minority stress model, or this idea of stigma-related stress, with an adaptive coping model, which essentially says a crisis rooted in adverse social determinants of health, for example, traumatic experiences, is really an opportunity to develop health-promoting behaviors rather than health risk behaviors. So instead of tobacco use, substance use disorders, binging and purging, high-risk sexual activity, one might learn to engage in regular exercise and healthy diet as forms of self-care. Instead of engaging in identity concealment, being socially isolated, and in the context of healthcare mistrust, having low engagement in routine healthcare, folks may experience an opportunity to manage their identity in a more adaptive way, to learn coping strategies, to be engaged with community, and to participate in routine healthcare and maintain that engagement. All of this can lead to potentially positive physical and mental health outcomes, as listed here. Next slide. Here we have some minority stress treatment principles for clinicians. These are principles based on the minority stress framework I showed, kind of trauma that stigma can result in. And we can infuse this in the care we provide our patients. Advance to next bullet, please. Thank you. The first is to normalize the adverse impact of stigma or minority stress. Many people who have stigmatized identities or marginalized may attribute challenges in their life to personal failing rather than the stigma that they experience and the marginalization that they experience in society. So we have an opportunity to name that and help people discern when this is occurring so they can more accurately attribute challenges in their life to various social determinants, to stigma, for example, when that is indeed the case. And that can be very liberating. Next bullet, please. Facilitating emotional awareness, regulation, and acceptance, the pathway by which stigma as a social determinant can potentially lead to post-traumatic stress symptoms, as we reviewed a couple of slides ago. And your behavioral health clinicians you work with at your health centers will have skills in promoting emotional awareness, regulation, and self-acceptance. Next slide. Empowering assertive communication. Marginalized communities, for better or for worse, have to be advocates for themselves within healthcare. It can be valuable to do assertiveness training so that people learn to communicate not in a passive way or in an aggressive way, but down the middle in an assertive way. Next bullet, please. Restructuring minority stress cognitions, or beliefs that stem from experiencing chronic stigma and minority stress. It's not all bad. People with stigmatized identities, marginalized communities have tremendous resilience. Typically, over time, over the years, have overcome tremendous obstacles in society. They're helping particularly younger patients who experience stigma as a social determinant feel more connected to the strength and resilience of their community can be very empowering. Next slide, please. Next bullet, thank you. Fostering supportive relationships and community. It can be, particularly in rural settings, very easy for people to isolate. I was just this morning, on the rural border of Oregon and Idaho, and was hearing stories about how disconnected some people in the community feel, and in another sense, how close-knit this very rural, thinly populated, but supportive community is. So there are two ways that this can go in rural settings, and certainly the champions on the ground at the health center I was just visiting have very proactively fostered relationships and community among the rural residents of the county. Next slide, please. Important to note the relationship of trauma and substance use. We're certainly in the health center program at HRSA more broadly very focused on substance use disorders, particularly the opioid epidemic more recently. Important to understand how centrally addictions and substance use disorders play a role in trauma. Co-occurrence of substance use disorders and post-traumatic stress symptoms is highly prevalent. This co-occurrence is associated with increased treatment costs, decreased treatment adherence, and worse physical and mental health outcomes. We need to address both. To get traction on someone's trauma symptoms, we need to support them and treat their substance use disorder, and vice versa. If we want substance use disorders to get better, we do need to address in an evidence-based way post-traumatic stress symptoms that our clients may be experiencing. Next slide, please. As I mentioned briefly earlier, we think of post-traumatic stress disorder in three domains. There's intrusion, intrusive thoughts you can't get out of your head, avoidance or numbing, and hypervigilance, hyperarousal. We think of substance use as a common avoidance strategy or numbing strategy for post-traumatic stress. The way trauma works is that when someone has either acutely or over time an inescapable stressor and could be an adverse social determinant like chronic stigma, for example. It can be adaptive in some ways to dissociate so that you don't cognitively and emotionally experience the pain of this adverse traumatic experience. That said, over time, if you never process the experience cognitively and emotionally, you're not going to recover from the traumatic experience the way that someone else might. So many evidence-based trauma treatments really conceptualize avoidance as the heart of post-traumatic stress disorder, for example, which is viewed in many cases as a disorder of avoidance, and that's what you need to address, which can be very challenging. And luckily, we have some excellent evidence-based approaches that we'll talk about today. Next slide, please. There's also more openness to integrated treatment for trauma and addictions, a recent shift in community addictions treatment settings toward trauma-informed care, and a favorable environment for evidence-based integrated therapies that target trauma and stress in addition to addictions. We call this dual diagnosis treatment. That's treating addictions and also symptoms of trauma. Next bullet, please. There's great evidence showing that integrated treatments for addictions and post-traumatic stress are well tolerated and improve both substance use disorders and PTSD. Next slide, please. One such treatment is cognitive processing therapy for PTSD. This was developed by Patty Resnick and her team initially for women who are sexual assault survivors. And this can be adapted for many of our clients. The focus of this treatment involves, next bullet please, thank you, educating patients about post-traumatic stress so they understand the connection between their life experiences, for example, various adverse chronic social determinants, and their thoughts, emotions, and behaviors. Next bullet, please. Writing an impact statement to understand how trauma influenced the person's beliefs about themselves, about other people, and about the world around them. So we'll typically do that in various domains based on Maslow's hierarchy of needs, which is very helpful to think about in terms of social determinants as well. So the domains in which the impact statement is typically written include safety, power, intimacy, self-esteem, and control. Identifying maladaptive thoughts about adverse life experiences that are linked to emotional distress. And if we reframe those thoughts, those beliefs, can reduce emotional distress if the beliefs are less rigid and more based on reality. Next bullet, please. And really focusing on decreasing avoidance of processing challenging life experiences and increasing resilient coping. Next bullet, please. Great. This is from SAMHSA. This is what's called the cognitive triad of traumatic stress. These are the kinds of beliefs that can emerge with persistent, challenging life circumstances or frank violence or other traumatic events or experiences that people may have. A person's views about themselves may change. They may come to believe that they're incompetent, that they should have reacted differently given the circumstances, that life is too much for them to handle, and they may feel damaged. Views about the world may change, that the world is a dangerous place, people can't be trusted, that life is fundamentally unpredictable. And views about the future may change. Things will never be the same. What is the point? I'll never get over this, and it's hopeless. So start to think about your clients in rural settings and the ways in which these kinds of beliefs may emerge related to various social determinants that people may be experiencing regarding decreased opportunities for employment, education, transportation, social isolation, and these kinds of beliefs can really develop chronically from being in resource-limited settings in those ways. Next slide, please. Important to think about trauma-informed approaches holistically and pervasively within our health centers. For example, in a waiting room, if you have chairs all closely lined up next to each other where people are elbow to elbow waiting to see their clinicians, that may not be the most trauma-informed way to go if someone has a history of assault, for example, and doesn't feel comfortable in that way. So maybe you could instead have some chairs that are not closely stuck together with other chairs so that people can sit with a little more space and distance and not be triggered in your waiting room. Also important to think about things like the physical exams that we do and certain ways in which we can reduce the likelihood of re-traumatizing our clients when we do these. We can offer an overview of the exam procedure we're going to do, use the language that the patient themselves would like you to use for their anatomy. You can ask every patient what could be done to help them feel more comfortable during the exam. Make sure that the locus of control during the exam is with the patient at all times, and let them know that if they say to stop, you automatically will do so. And to respond appropriately if the exam happens to trigger an acute stress reaction. So to provide grounding exercises, for example, so that people maybe come back from dissociating and can be more present and work through the triggering nature of the exam. Next slide, please. A trauma-informed service environment broadly is one that promotes a sense of safety for all, that ensures staff understand how prior traumatic experiences influence reactions and subsequent interactions with staff, like the process of seeking care, how a history of interpersonal trauma, like intimate partner violence or hate crimes, which are very much a social determinant of health, can contribute to mistrust of caretakers in turn and increase the likelihood of being re-traumatized in healthcare settings. Retention and care for patients with trauma histories requires engagement through collaboration, transparency, trust, and being consistently supportive. Next slide. We want to screen for trauma and identify its mediators as well. We want to screen all patients for a trauma history as a standard practice within our health centers, with extra attentiveness for subpopulations with an even higher risk of trauma who may be even more sensitive. This may include migrant workers in rural settings, for example, who may not be documented in the work that they're doing in the US. You also want to screen separately for intimate partner violence, which is a unique kind of trauma that people may experience. If trauma as an experience is identified, we then want to assess specifically for symptoms of post-traumatic stress, because people can have traumatic life experiences. It doesn't mean that they have symptoms related to this. So the kinds of symptoms we want to look for are hypervigilance, avoidance, numbing, re-experiencing the trauma through intrusive thoughts, flashbacks or nightmares, and psychological dissociation, so detachment from reality, including amnesia, depersonalization, where you feel disconnected from your body, and derealization, where you feel disconnected from the space around you. Next slide. This is a primary care PTSD screen that SAMHSA features. It asks, in your life, if you've ever had an experience that was so frightening, horrible, or upsetting that in the past month you had nightmares about it or thought about it when you didn't want to, tried hard not to think about it, or went out of your way to avoid situations that reminded you of it, were consistently on guard, watchful, or easily startled, and felt numb or detached from others, activities, or your surroundings. Next slide. This is an intimate partner violence screening tool, the STAT intimate partner violence tool that is also on SAMHSA's Trauma-Informed Care National Center website. Have you ever been in a relationship where your partner has pushed or slapped you? Have you ever been in a relationship where your partner threatened you with violence? Have you ever been in a relationship where your partner has thrown, broken, or punched things? Next slide. Thanks. And if people have these traumatic experiences, then you can use something like the PTSD checklist, the PCL5, that really gets into symptoms of PTSD and gives you a sense of whether a person has symptoms of post-traumatic stress or full clinical PTSD even in some cases. Next slide. I mentioned the importance of fostering, cultivating resilience with our clients. What is resilience? It's the ability to bounce back or rise above adversity as an individual, family, community, or provider. Well beyond individual characteristics of a hardiness, resilience includes the process of using available resources to negotiate hardship and or the consequences of adverse events. So you see it's a very broad definition and something that is key for bouncing back, as it says here, rising above the adversity of various negative social determinants of health that our clients may be experiencing. Next slide. These are some resilience promoting questions that are strengths oriented, like the history you provided suggests you've accomplished a great deal since the trauma. What are some of the accomplishments that give you the most pride? What would you say are your strengths? How do you manage your stress today? What behaviors have helped you survive your traumatic experiences? What are some of the creative ways you deal with painful feelings? Next slide. Just a couple of more. What characteristics have helped you manage these experiences and the challenges that they created in your life? If we were to ask someone in your life who knew your history and experience to name 2 positive characteristics that helped you survive, what would they be? And how do you gain support today? From family, friends, activities, coaches, counselors, or other supports? And what does recovery look like for you? Next slide. An important note about disseminating and implementing trauma-focused treatments in rural communities. As we know, rural communities will often have decreased access to specialized mental health services or to health services in general, which can present a major problem. Means that it's harder to have these treatments penetrate rural communities. Evidence-based psychological treatments that have been shown to be effective at improving symptoms of depression, anxiety, in response to traumatic experiences. Often barriers include long distances that need to be traveled to reach services. In rural settings, time folks have to take out of work or school to leave their rural communities to go access these services, and a lack of access to transportation in general to even get to wherever there may be more evidence-based trauma-focused treatment available. Next slide. For all these reasons, telemedicine is a very exciting tool, a powerful tool to bring evidence-based trauma-focused treatment to rural settings. This is internet-based teleconferencing that can be protected for confidentiality reasons, and it enables live and direct virtual access to specialized mental health services. This is being used more and more in rural health centers. The laws are a little different from state to state in terms of what's possible, and also in terms of whether treatment can happen across state lines. It can be quite tricky. We're trying to implement this with rural health center in Western Massachusetts, and some of the clients live in New Hampshire or Vermont or upstate New York in rural settings, and they have to physically be in Massachusetts when we do this work, where I am in Boston, even if they're in Western Massachusetts, for it to be permissible. Another very compelling tool that's emerged are eco-learning models and programs to disseminate evidence-based treatments like trauma-focused treatment and trauma-informed care to rural health centers. ECHO is a fantastic model. We do this through the National LGBT Health Education Center, where we have a transgender ECHO. For a year, health centers commit their integrated primary medical care and behavioral health teams to train up in transgender health, the big focus on social determinants, gender minority stress, and we make a point of having a nice mix. About half of the 24, 25 health centers in each cohort, and we've done about 4 cohorts now, have been intentionally from very rural settings throughout the country. And it's a wonderful way to get expertise and best practices democratized and out to rural settings by training up teams, where we do a didactic session and then can do case consultation, where folks in rural health centers present their cases to us, and we, with a panel of clinical faculty, will facilitate a discussion to identify treatment plan and options for that case. There are some unique confidentiality-based considerations, obviously, with this kind of remote teleconferencing. These are being worked out at state levels. This is something HRSA is very interested in as well. So certainly more to come in terms of harnessing and deploying the full power of these distance-based tools for rural settings. Next slide. Great, and I'll now turn it over to Theresa.
Wonderful. For those of you who may have missed the introductions, my name's Theresa Lyons-Clampett, and I'm a senior grants manager with Migrant Clinicians Network, a national training and technical assistance organization. You've heard a lot of really great information from Alex about the intersection of trauma and social determinants of health. And as a practicing clinician, Alex has so much valuable insight into these issues. What I wanted to do today is to spend about 10 minutes talking specifically about how you might see trauma in migrant and agricultural workers in rural health centers. I really want to highlight the population as a way to illuminate some of the ways trauma might manifest itself in this particular population. And it's my hope that thinking about the needs of this population will spur some thinking about the unique ways in which trauma can impact many other populations you serve in your health centers. Next slide. We'd also like to remind people that not all agricultural workers are migrants. At the same time, migration, either internal in the United States or from outside the United States, can itself be a source of trauma. In many cases, the loss of family and other social networks is traumatizing and results in feelings of isolation. This extends into feelings isolated from systems designed to support health, wellness, and other social services. Next slide, please. And very directly, migrants, especially those from outside the United States, are either fleeing violence in their home or experience violence during the migration process. Many of the people who do migrate are extremely resilient and may have found ways to cope with the violence or other threats, but this has an impact on their health and well-being as well. Next slide. We'd like to point out that many of the challenges facing agricultural and other mobile patients are very similar to those facing other low-income, marginalized rural populations. However, there are some critical overlays from migrant and agricultural workers that exacerbate these challenges. We've talked about the vulnerabilities and experiences of trauma during migration, which can make it difficult for those patients to trust the system. This is particularly true in times of heightened rhetoric and action against immigrants. It's important to note that not all migrants are immigrants, but there are lots of crossover in those populations which ultimately end up impacting everyone. Occupation is also a critical social determinant of health for agricultural worker patients. And understanding where someone works and the dangers inherent in that job are critical to being able to effectively work with patients to improve health. And finally, challenges to accessing financial and insurance resources prove to be a significant barrier. Next slide. Unfamiliarity, perhaps, with how healthcare systems in general work in the U.S. or fear and unfamiliarity about a new location creates a risk for mobile patients every time they move. They question, will they be accepted where they are going, or will they be turned away? Will there be someone there that understands their language? And then again, this repeats every time they move, and it adds to the trauma that they may already be experiencing. Next slide. Many highly mobile people have left their home countries because of violence or extreme poverty that threatens their lives. The violence can come from unrest in the community or from within their own homes with no protections available. Next slide. Most populations also encounter stigma and discrimination. Many times they're wrongly characterized as criminals, lazy, or unintelligent. These mischaracterizations can add to the frustration and their trauma, We have a lot of anecdotal evidence from providers in our network that immigrants and migrant patients are experiencing increasing levels of stigma in local communities, which is causing greater isolation and fear. Next slide. These experiences can cause issues with mental health as well as affecting physical health. Alex has talked about how health centers can better understand how deeply intertwined trauma and social determinants are for many of our patients. As health centers learn to identify trauma as well as begin to address social determinants of health, we will greatly improve our abilities to really impact the health of these vulnerable populations. Next slide. There are a few things I want to remind you about as you think about the intersection of trauma and social determinants of health in your health center. First is that people who have experienced trauma can look and sometimes act just like any other member of the community. This is why it's important for health centers to have systems in place to be able to dig a little deeper to fully understand the patient's reality. Second, people respond very differently to traumatic events, so never assume you fully understand how someone is feeling or reacting to a given situation. Third, as a health center, it's important that you provide the same level of care to all your patients, so developing systems to address social determinants of health is really critical. And then finally, when we're working with migrants, the social determinant of health they're dealing with may very well supersede their ability to engage with the health center. If they need to pursue crops for money, this need is going to come first in their list of priorities. And understanding the hierarchy of their needs is critical in being able to effectively engage that patient. Next slide, please. I wanted to leave you with a case study that illustrates how social determinants of health can impact the health and well-being of a migrant patient. This case study, I'm going to call her Miss Galvan. That name has been changed to protect her identity. But she's a 39-year-old pregnant farm worker who presented as a new patient to a community health clinic. She told her new family physician that she had already received an ultrasound, a pelvic exam, and screening for glucose tolerance and communicable diseases at another clinic in a nearby state, but no records had been forwarded along with her. This woman is a migrant berry picker who moves every 3 to 6 weeks to a new farm. Her five children live with their grandmother in Mexico, and she presented to the doctor expressing concerns that her unborn baby was not moving. After an examination and more discussion, she shared that she had been experiencing a depressed mood following the suicide of her 12-year-old daughter in Mexico during her absence in a prior farm session. As the primary breadwinner for her family, she was intending to work until the last days of her pregnancy and was preparing to move to a new region 1 week after this clinic visit. She also lacked authorization to live in the United States and was not eligible for health insurance in the state where she had presented for care. Her new doctor was concerned about the grave risks of pregnancy complications Ms. Galvan faced as a woman with advanced maternal age, engaged in daily heavy physical labor with exposures to pesticide and heat, uncertain nutritional and water intake, and depression. Her doctor repeated appropriate exams and screenings, but wondering how these results would be conveyed to Ms. Galvan effectively, as she would be moving again for 1 week from the appointment in which she had, and before her tests would come back or before even an appointment with a therapist could be arranged. Because of her mobility and previous trauma, extra care to stay in touch with her would be necessary. As a result, Ms. Galvan's doctor enrolled her in Migrant Clinicians program called Health Network. It's a bridge case management and patient navigation service. So she could have assistance in making her appointments and receiving prenatal and mental health care as she needed. Ms. Galvez then moved to three different in-state farms every 3 weeks for work. And each time she moved, the health network associate contacted a new clinic, moved her medical records, and communicated with her about her appointment. This frequent communication helped build trust and reinforced to Ms. Galvez the importance of the continuity in medical care that she was receiving. After 7 moves in 7 months, and despite some inconsistent care, Ms. Galvez gave birth to a healthy baby boy at 38 weeks of gestation. The health network contacted Ms. Galvez 5 more times over 4 months to case manage her postpartum care until Ms. Galvez moved back to live with her mother and children in Mexico 5 months after giving birth. Ms. Galvez then reported to the health network associate that her depression had lessened after she ceased migrating and returned to her community and support system. Health Network is a free patient navigation service provided to federally qualified health centers for their mobile patients. This service is part of MCN's National Cooperative Agreement with the Health Resources and Services Administration, and links to this information will be provided to you along with the slides and other resources for the presentation. I will now turn this back over to the organizers and to talk to you about the Q&A portion of the presentation and our next steps. Thank you.
Thank you, Theresa, and thank you, Alex. And as we did last week, and as we'll do for the additional 2 sessions, we wanted to make sure that we gave you all the content that we had prepared within the first hour, and we can take up to an additional half hour for discussion, for questions from our presenters. We definitely want to take advantage of your opportunities to learn from each other and to get your questions answered. So if you have a question for a panelist, please type it in the question box or raise your hand. We can unmute you. And Alex and Theresa, if you have guiding questions you want to throw out or anything that you want to expand on, feel free. I will throw out some guiding questions to try to get the conversation started too. But as I was listening to both of your presentations, which are just excellent, I was curious to know from our participants, what are some of the practices that you all are using in your health centers to help your patients feel safe and feel in control, and if they are experiencing trauma, to sort of help keep them from being re-traumatized? Are there some practices that you'd like to share with the group that you use that really get at helping people feel safe and control in your setting? Go ahead and raise your hand or type it into the chat box if you have something that you'd like to contribute. And I was also wondering, Theresa made the point that by highlighting the experiences of trauma that agricultural workers certainly present with, what came up for all of you? Did you think of other populations that you're serving that tend to present with really sort of common experiences of trauma, or did you think more about what you're doing to serve agricultural workers? What are you seeing in your patient populations? Who are you seeing regularly that are experiencing traumatic events, and you might be proud of your approach, or you might want to learn more about how to approach them better? What questions might you have for the facilitators? When you heard from Alex and Theresa, what came up for you as confusing or really interesting that you might want to learn more about? Alex presented a couple of different screening tools and resources from SAMHSA, for example. Has anyone used any of those, or do you have questions about any of those? Here's a question from Megan. Can you recommend specific forms for initial intake that address social determinants of health in a way that captures the information but doesn't seem threatening to the patient? So can you, Theresa or Alex, can you recommend any specific forms or processes, or anybody else who's in our group today? Specific forms for initial intake that address SDOH, captures that information but doesn't seem threatening to the patient. Does anybody have thoughts about that?
Rita, do you want to start us off?
Sure. One thing that I have experienced personally at the community health center that I go to, when I arrived and checked in for my my appointment, I had someone who met with me prior to the appointment who presented me with kind of like a questionnaire or survey that asked some questions about kind of similar to the questions that Alex put on the screen earlier in the presentation, that just asked about my experiences at home and my level of feeling blue. And so it was a pretty non-threatening little questionnaire that was asked of me before I went in to see my doctor, so that they had that in my file. And if there was something there on that questionnaire, then the doctor could spend a little more time fleshing that out and making a referral. So that's one personal experience that I've had around those types of questions.
Theresa, was that just in the, I've started seeing that too in clinicians' offices. Was it just part of the regular intake form that you fill out every time you go in, asking about health experiences you're dealing with that day?
Yeah, it felt like it. It did feel like it. It didn't feel like they were targeting me or pulling or specifically, thinking I had a problem they wanted to get more information on. It really did feel like this is something that we're asking all of our patients to tell us about.
Great. We have a couple of more questions. I'm going to group these, but I see one that's related to this. Thank you, from Shelby, saying that the way I conduct assessments is to break up into multiple sessions so that we can include talk story type approach, which is less structured and not really pressed to complete the contents of the documents. It's a more narrative approach that allows stories to evolve. Shelby, I'd love to unmute you and have you speak a little bit more to that, if you're comfortable with it. I think I can do that, Liam. Shelby, you're unmuted. Do you want to say a little bit more about that?
Hi, this is Shelby from the Molokai Community Health Center in Hawaii. In Hawaii, is there anybody else from Hawaii?
I don't know if we have anyone else from Hawaii on the line today. If someone else is from Hawaii, do you want to raise your hand?
I wish I were from Hawaii.
So Hawaii people are really about geographical connections and those kind. It's about genealogical connections and geographical connections. So whenever we meet each other, we kind of go, "Oh, where are you from? Who's your family?" Those kinds of things. So typically, so what I do is kind of allow that kind of information to flow into the conversation, so that and then interject some of the questions that I have to be pressed to have them answer. So kind of just I don't know, interjecting these kinds of questions, talking story, and then some of that information will come out so that their story kind of evolves and things like that. So that's a lot better at developing rapport, I think, rather than kind of having them come into the office and then we'll go, boom, okay, what's your name, you know, and all this kind of real personal information. And then asking some more broad type, I guess, trauma-directed information, asking more broad. For example, asking the clients, you know, we call it lickings, getting lickings. So yeah, lickings.
Okay.
So the culturally, so our cultural language is in Pidgin is like, so what? You get lickings from your father or your mother? So we ask them like that. So the question is, do you get lickings from your mom or dad? And yeah, so that will kind of lead into a different kind of discussion. So I don't know, this kind of I think this kind of methodology takes a little bit longer. So in Hawaii too, we have this expression that says, we pau when we pau. So in other words, the event or the thing that we're doing, the activity is finished when it's finished. So we don't put necessarily time limits, although, you know, within the Western model, especially kind of CHC is we have appointments to follow. We try and stick within that. But it's just, that's the kind of interplay that happens, I think, within our context anyway.
Great.
So does that, sorry.
Oh, no, it's okay. You had asked if anyone else was from Hawaii, and Megan Cunningham mentioned that she's with the Community Clinic of Maui. Do you think that the approach that you're talking about is especially relevant for folks in Hawaii because of sort of cultural or social issues, or do you think it could be equally effective in any rural setting?
So I operate out of Maui too, so I kind of have an idea about what the Maui context, but I think it's very specific. So the farther you go away from Oahu, the more rural it is, and the more so the islands are very different. Maui is very accepting of outside influence. You have Kauai that is not so much, and then even more close to outside influence is Molokai. And then you have the island of Lanai, which is privately owned by the guy who owns Oracle.
Oh.
Yeah. So, and we're all very geographically isolated in terms of Maui is separated from Oahu by ocean. Same thing with Molokai and Lanai.
Great. And and Megan, did you have a comment? I unmuted you.
Hi, can you hear me?
Yes.
Yeah, that is very true. I love hearing from someone who's lived here a bit longer. I guess what I was understanding from some of the folks that do the initial intake at the front desk, some of them are really young and they maybe don't necessarily feel comfortable with asking questions. So for the initial intake, the idea of using some of the questions that Alex presented is a great idea. And I guess kind of being able to make it comfortable for both the person at the front desk and for the patient. And then I think when they speak with the provider, that's when more of the talk story might be, they might be able to do that more easily and more comfortably. But it's a combination, I think. We want to capture and make sure we're getting everybody.
Thank you so much for that. We had some questions from Kevin Walsh on a different line. Kevin commented that they see homeless and itinerant folks frequently and was interested. He said the network approach which Theresa described for migrant farm workers is excellent. Are there similar networks for other people in need? So Theresa or Alex, do you know of any other networks, additional networks beyond what MCN is doing that people can help get connected to with?
I think probably a better question for Theresa. Why don't you?
Yeah, I was going to say I'm unaware of other services like our health network, but if I didn't make it clear in my presentation earlier, that service is for mobile patients, so highly mobile patients. Homeless can sometimes fit into that depending on what their lifestyle is like. And the reason why our service works so well for and is needed for mobile patients is that that bridge case management and the patient navigation to other health centers as the person moves along. That is really the help that we can offer to help people live up to their full potential of their health, and it allows us to stay in contact with them as well. So in some cases, I guess what I'm saying is, in some cases, homeless or other highly mobile populations are also helped by Health Network.
Got it. Sure. So it doesn't just have to be for farm workers, right, Theresa?
Correct.
Okay. And Kevin sort of built on this, so this might spark additional ideas from the group as well as the presenters, but he talked about how they're trying to build a county-wide care coordination platform in a rural county, but their resources are really scarce and inadequate. And so when you think about how can we do a care coordination network on a really tight budget, I'm wondering if any of you have tools you use, strategies you use, collaborations that you've engaged in that are especially effective. I know we ran a program for a little while where we used the platform Aunt Bertha, which allows for some community level care coordination, and there are free levels but then also paid levels, and I've heard of other people using Aunt Bertha for some sorts of care coordination activities that might be a little lower budget. But what are some care coordination platforms or processes or tools that you all use or that our presenters know about that might be affordable and effective?
That was Kat.
Oh, sorry, Kevin, I have you unmuted if you want to say more. I think I'll mute him back up again. Okay, he's muted. Let's see. Okay, Tricia says, any rural areas, I've noticed that Aunt Bertha resources may be geographically challenging to access. Yeah, I think that's probably true, Tricia. Our experience was we were doing a learning collaborative with 4 different communities, and for a period of time, we bought memberships basically to Aunt Bertha, and as part of that deal, they really beefed up the resources in those communities. So the paid portion allows you to really beef up the resources that are included in that database. But if you're just using the free portion, it may not yield much, especially in rural areas. We have another question from Deborah Rivera. We're currently not screening for social determinants of health. As we move forward, would it be best to have the behavioral health staff meet with the patients once the medical providers identify the need? That might be something. So if medical providers identify the need, Alex, Theresa, or our participants, what's your approach? If you have a medical provider identify a need, then do they get them right to behavioral health providers, or how are people managing this?
That's a great question. This is Alex, and we have several evidence-based models for this, and we call it collaborative care. So there's the psychiatric collaborative care model, developed by the University of Washington, for example, that was originally used for depression diagnosed in primary care, and then connecting the patient to behavioral health services once this screening happens with a PHQ-9, for example, in primary care. But it's been expanded now beyond just depressive disorders or anxiety disorders. So we can think about models of collaborative care between primary medical care and behavioral health within health centers that are for post-traumatic stress or a variety of other disorders. In that particular collaborative care model, the idea is that you'd have a psychotherapist or a psychiatric prescriber, and you would try to reduce symptoms by about 50% over a period of time. So the initial treatment plan is developed with the, say, psychiatrist, behavioral health clinician, the psychotherapist, and then it's really managed in primary care by the primary care provider and, in the original model, a depression care manager. And then you would check in in, say, 10 weeks and see whether the scores for depression have dropped by 50%. If they haven't dropped that much yet, then the psychiatrist would get involved in adjusting the treatment plan to try and bring those depression scores down further. So there are cool models like that for how this can happen. I definitely think for patients who screen positive for post-traumatic stress disorder in primary care, using those tools from SAMHSA that I showed, they do need to be connected to behavioral health. I think it's just the case, unfortunately, that primary care providers aren't going to be trained in evidence-based behavioral health treatments for PTSD. And ideally, you would have someone in your health center who is trained in evidence-based practice in cognitive processing therapy, for example. But that's not always going to be the case. So in those situations, thinking about telemedicine-powered models could be the way to go.
Thank you, Alex. Shelby actually made a comment that is kind of related to this, saying that on Molokai, some areas are so rural, making our reach via telecommunications, the spotty coverage makes that very challenging. So that is something that can be really valuable in rural areas and also come with some challenges that you have to work around.
Definitely, and that was in the article I sent about telemedicine for trauma care in rural settings. One of the barriers is really connectivity, and that's, you know, in a sense, that's a social determinant in and of itself, right? That in rural settings you don't have the kind of bandwidth and the kind of you know, internet access that you do in urban settings. I certainly, on my drive yesterday to the rural Oregon-Idaho border, had no reception of any kind for a while, which is not something I ever experienced in Boston. So there are real disparities there. There are real, you know, that's a social determinant in and of itself.
Interesting discussions. Going back to the question of how sort of care coordination models and screening processes that can be lower cost. Shelby also mentioned that they use the Prepare tool, and their version they get some funding from Blue Cross Blue Shield to implement the Prepare tool. And then Suzanne Smith mentioned, she says, we have our own network through our Rural Health Network, which includes over 55 dues-paying organizations, and we have a connectors program that connects people to resources, and then everything is documented, including the follow-up. Suzanne, I'm gonna see if you're available to chat. I'll unmute you for a second if you want to expand on that at all. You are unmuted if you'd like to expand on that, Suzanne. Okay, I'm not hearing anything from Suzanne, but I am curious, you know, what the dues, this Rural Health Network that has dues-paying organizations, and knowing that cost can be a real barrier for some organizations, but I wonder if there are programs like this that have sliding fee scales, perhaps, that the size and budget of the organization might determine how much or how little you would have to pay, because I do know that when budget is an issue, that's really important. Okay, and yes, and Shelby was commenting on Alex's previous points about the spottiness of coverage and also transportation, as stated in the article that Alex sent out, being a real barrier in rural areas.
Yeah.
Great. Any other questions for the panelists, questions for each other, comments about any of the things we've been talking about? I had some other questions that I wrote down. I'm going to look at those. I was curious how people were screening, and we've heard some people using Prepare, some people using client intake, some people using the sort of provider conversation to get to some screening and then get referrals to behavioral health providers. We've talked a little bit about using telemedicine. I'm curious if others of you are using telemedicine to try to address trauma, PTSD, other social determinants issues. If anyone is using telemedicine effectively or using it but being challenged by it, if you'd like to comment on that and talk about it a little bit, we would welcome it. Oh, sorry, Suzanne, I'm gonna re-unmute you. I couldn't hear you. Let's try. One moment. Suzanne, you are unmuted. Let's see if I can hear you. Can you talk? Darn, it's just not working. Okay. Let's see. Shelley is with HCC of rural Missouri. Shelley, did you have a comment or a question for the group? Oh, and can help to answer for Suzanne. Let's unmute Shelley. All right, Shelley, you are unmuted. Let's see if we can hear you.
Can you hear me now?
Yes.
Okay. I realized I had muted myself as well.
Right, double muted.
So yes, for our memberships, we have different pricings. We have individual members and associate members. One is $150 and one is $250. The other one is a partner membership, which would be $500. And so various items are included with the level of membership that you would be paying for.
Is that like $150, $250? Is it per person or per organization? That sounds really reasonable, but yeah.
Right. If it's an individual member, that's the $150 per person. And then we have and then like if it's a partner member, here's Suzanne here. Okay. So if it's a partner member, can any of those organizations members come from that?
Right. And this is an annual membership. So it runs from July 1 through June 30th because that's our fiscal year.
And this is so this is a rural health network, and it's a connectors program. Can you describe the program a little, and can you tell us if people in other states, what state you're in, and if people from other states could somehow explore this in their own settings, or is it specific to your state?
I'm sorry, would you say that again?
Yes, I just had about 10 questions embedded in my one question. I wanted to ask you if you would describe the program a little bit and tell us if it's specific to your state or if it's something that if others were interested in being a part of it, if they could join from other states.
They can join from other states. We serve a 5-county area in central Missouri, so we're a rural health network, and we're the first one to also own and operate our own federally qualified health centers. So the membership that we have allows folks to come and meet monthly. Like today we had our membership luncheon. We bring a different guest speaker in, and then those organizations can also be part of our connectors program, which is what I was alluding to, where we meet. We have put together a huge event called Project Connect, where we serve those who are uninsured and underserved. We also have a 7,500 square foot warehouse where we glean items that that can't be bought by food stamps, like personal hygiene items, mattresses, sheets, personal hygiene items, that kind of thing. And then we also do, we have a transportation initiative that we do. We have 2 school-based telehealth clinics, and all of that falls under the network that I'm in charge of. But we also utilize the Prepare tool and utilize that to screen in both our clinics and on our network side. So we focus heavily on the social determinants of health. And I would be happy to talk to anybody that would want to start something like this in their own organization.
That's great. Thank you. And this was Suzanne, right? You're expanding on that?
I'm sorry, I came over to Shelley's desk.
Right. Good. Well, this is great. And I think it really highlights the value of sort of collaborating with your community and state partners where possible to bring down costs and increase the amount of resources available for your patients and your community members.
Yes.
Are there any other questions for each other or for the panelists, or things that you would like to share with us that you've experienced either successfully or as a challenge when it comes to addressing trauma in your rural settings? Okay, I'm hearing from Ashley. In our clinic, we have what is called a patient navigator. This person is actually a member of our behavioral health team and is the first person that our clients meet with. She completes all intake paperwork and screenings with the client and then schedules them with a provider. She also serves as an introduction to services and oftentimes initiates a warm handoff to our counselor or case manager if needed. Fantastic. Ashley, I will try to unmute you if you want to expand on those comments a little bit, if you're able. Ashley, you are unmuted.
Can you?
Yes.
Hi, yes. In our clinic, we've kind of developed a team that has started out with just one case manager initially, and then we've grown so much that they've kind of developed a few other positions. We now have 2 case managers, and we provide services such as we operate a food and outreach center, we have a fitness center up here, we have a few other small little services that we provide, maybe in-home visits and things like that. But our newest position is our patient navigator. And that has actually helped us to find some of our new patients, specifically some of their needs, and discover best how we can serve them. So this person is trained with our case managers, and in a lot of ways she is a case manager, but her job specifically is to start at the clinic with those new patients, and she completes all of her screenings and kind of goes through step by step and kind of helps get notes to the provider. Maybe we have someone who has, they maybe cannot read very well and they tend to be intimidated. So then our providers can know those things to start with. And then there's been times when we've had patients come in that have experienced, trauma, or currently we're up higher in Northern California. So we've had, people, evacuees from the car fire. We've had, people traveling through the area and sometimes in crisis. So at different times, maybe they bring in our counselor or our psychiatrist if it happens to be a day that she is here, and we can do a warm handoff that way and have that immediate intervention.
Oh, wonderful. So it does sound like you don't necessarily have to bring them back for a separate appointment. You might be able to do it all while they're already there.
Definitely. And we one of the things that we really try to do here is to have some of those same day appointments, and we have, you know, our BERT team. So there's a few different options if something is needed. We do definitely try to have that time to do those in the moment, because sometimes those triggers happen now. It won't necessarily do any good if I make them appointment, you know, next week.
Sure. And is that, are they, I think it's really interesting and exciting that this patient navigator is actually a member of your behavioral health team. But am I understanding correctly that it doesn't necessarily have to be, like, would she screen someone regardless of whether or not they have an appointment or a specifically identified behavioral health need coming up?
Yes.
Or is she just
No matter
screening
what.
all of your patients? Great.
Right.
Well, that's exciting. We do love learning from all of you. That is a huge benefit of this learning collaborative model. I appreciate all of your patience with trying to communicate in this challenging way. I'm going to mention one final question, and then I'm going to ask Alex and Theresa if you have any parting comments for us, and we'll talk about next steps and we'll wrap up. But there was one additional question from Megan asking if we have any case studies of community health workers successfully addressing social determinants of health and increasing patients seeking care. That is a great question. I'm sure case studies are out there or articles are out there. I personally don't know of any offhand. I'm not sure if Theresa or Alex or Christina, if you know of any offhand, but it's certainly something we can look into. And if any of our participants have some right off the bat, if you could email us, we can share those with the group. So thank you for the question, Megan.
There's a model from Christie's Place in San Diego, which works with, serves people living with HIV, of using community health workers in their trauma-informed approach. It's called TIA Change. We're implementing this now through a different HRSA grant through the HIV/AIDS Bureau, but very effectively using community health workers. These aren't health centers necessarily, but Alaska Tribal Native Health Consortium does an amazing job of this. And we're working with them around implementing trauma-informed approaches, specifically using community health workers. There's a lot in the transgender health space in this regard, sort of identifying and cultivating community health workers to enhance linkage, engagement, and retention and care for trans women, particularly living with HIV. So there are some interventions like Healthy Divas and another one called Tweet that do this specifically. There are a lot of cases of it being effective. It's, you know, using community health workers is something that's intuitive. It seems like it would be effective, and in the cases that we've observed or been privileged to support, it really has been the case that it's a highly effective way to go.
That's great. Thank you, Alex. Well, we are just about at time. Our next session, we're not meeting next week. We're going to take a break for Thanksgiving. So I hope you all enjoy time with family and friends and eat some delicious food. But then our next session is also going to be hosted by National LGBT Health Education Center and Migrant Clinicians Network. And they're going to be talking about challenges and opportunities to collect SDOH data in rural areas. Alex, do you have any preview info you want to give folks? Do you think we'll send out any readings perhaps before that one rolls around?
I think so. Yeah, that one, Migrant Clinicians Network is taking a little more of the lead on. I took a little more of the lead on today's. So they'll be driving that, but we're going to be looking at how to harness data collection and utilize it to address social determinants. And I'm sure Jillian and Theresa will identify some readings in the next little bit to share with all our participants.
Yes, we certainly will. We'll get that sent out to everybody, and we're looking forward to talking with you after Thanksgiving about this topic further.
Just great. Well, thank you again, everybody. It was really delightful being with you today, and have a lovely, safe holiday, and we'll talk to you in a couple of weeks.